Welcome to our Advanced Heart Failure video curriculum series. In this video, we will discuss cardiogenic shock. Our objectives for this session are to define and describe the underlying pathophysiology of cardiogenic shock, list causes of cardiogenic shock and their effects on physiology, review the indications for and discuss mechanisms of action of inotropes and vasopressors used in the management of cardiogenic shock. Shock occurs when oxygen supply is not sufficient to keep pace with oxygen demands. Adequate mean arterial pressure, or MAP, is necessary to deliver sufficient oxygen to organs. Therefore, abnormalities that decrease MAP are responsible for shock physiology. MAP is best described by the equation MAP equals cardiac output times systemic vascular resistance, or SVR. In this video, we will focus on cardiogenic shock, in which low cardiac output is the primary reason for inadequate MAP. Cardiac output is the volume of blood that leaves the left ventricle per minute and is defined by stroke volume times heart rate, and derangements in either can cause cardiac output to drop. In response to low cardiac output, the body attempts to compensate and maintain MAP by increasing SVR, which increases afterload and can cause further cardiac decompensation. Cardiogenic shock can be caused by problems with systolic function, contraction, diastolic dysfunction, problems with filling or relaxation, rate or rhythm disturbance, and structural defects. Systolic dysfunction decreases cardiac output by decreasing stroke volume. Since cardiac output equals stroke volume times heart rate, when stroke volume falls, cardiac output falls. Ischemia from ACS is the most common cause of systolic dysfunction and of cardiogenic shock in general. Diastolic dysfunction occurs when thick, stiff ventricles have decreased compliance, which decreases the preload they're capable of accommodating and thus the stroke volume that they can produce. Extremes of heart rate and abnormal rhythms can also cause cardiogenic shock. Severe bradycardia drops cardiac output to an extent that cannot be compensated for by larger stroke volumes. Severe tachycardia drops cardiac output by decreasing ventricular filling time, decreasing stroke volume. Additionally, in tachycardia, diastole is shortened, which limits coronary artery perfusion. So at a time when oxygen demand is highest, oxygen delivery to the myocardium is impaired, which can further decrease cardiac output. Finally, structural abnormalities can also cause cardiogenic shock. Acute causes of mitral and aortic regurgitation are the most likely culprits for this, and both decrease cardiac output by decreasing the effective stroke volume. Even if the ejection fraction in these two scenarios is technically normal, the amount of forward flow from the LV with each cardiac cycle is low. It's important to point out that while problems in each of these categories can independently precipitate cardiogenic shock, multiple problems can occur in the same patient. Inotropes, with or without vasopressors, should be considered in almost all cases of cardiogenic shock. They should be used when you are otherwise unable to maintain a systolic blood pressure above 90, obtain adequate urine output with diuresis alone, or continue to have signs of end organ hypoperfusion despite initial management. Medical management is typically preferred to temporary mechanical circulatory support due to lower risks of adverse effects. However, if a patient is in cardiogenic shock that persists despite these medications, or if rapid support is necessary, consideration of MCS is warranted, which will be discussed in depth in a separate video. Medications that we most often think about when we think of cardiogenic shock are inotropic medications which increase cardiac output. There are two approved for use in the US, dobutamine and milrinone. Dobutamine is a non-selective beta agonist with greater affinity for beta-1 receptors, so its primary effects are ionotropy and chronotropy. It does this by increasing calcium channel activation in cardiac myocytes. Beta-1 effects increase heart rate and contractility, while beta-2 effects cause vasodilation, which contributes to one of its adverse effects of hypotension, which may require concurrent use of a vasopressor. It does have some alpha-1 effect that will counter some of the beta-2 vasodilation. Dobutamine can cause or worsen tachycardia and increases the risk of arrhythmia at any dose. Milrinone is a phosphodiesterase 3 inhibitor. Phosphodiesterase 3 is an enzyme that breaks down cyclic AMP in the cell. The end result of inhibiting phosphodiesterase 3 is an increase in intracellular calcium and thus contractility. Like dobutamine, milrinone also causes peripheral vasodilation, but unlike dobutamine, can cause pulmonary vasodilation, which can be beneficial in cardiogenic shock. It is also arrhythmogenic, though possibly less so than dobutamine. One consideration for the use of milrinone is its long half-life, which means that it can take several hours to reach steady state. It is also renally cleared and should be used in caution in patients with ESRD or oliguric AKI. So in the absence of ESRD or bad AKI, which inotrope should you choose? According to the ACC/AHA heart failure guidelines, the one your institution uses, the one you feel most comfortable with, or the one that's available. Evidence suggests that either dobutamine or milrinone are appropriate choices. The Capital Do-Re-Mi trial, published in the New England Journal of Medicine in 2021, was a single-center randomized trial that randomized all comers with cardiogenic shock to either milrinone or dobutamine, and found no difference in the primary composite outcome of all-cause in-hospital mortality, resuscitated cardiac arrest, need for transplant or mechanical circulatory support, non-fatal MI, TIA or stroke, or need for renal replacement therapy. Dopamine, isoproterenol, and levosimendan, which is not currently used in the US, are other ionotropic medications that you may hear about, but they do not have a significant role in the management of cardiogenic shock. It's worth mentioning that even though the use of vasoactive medications in cardiogenic shock is standard of care, there's not strong evidence that it improves outcomes, which is the subject of the Do-Re-Mi 2 trial that is currently in progress. That said, American and numerous international guidelines do recommend routine use of these medications in the management of cardiogenic shock. Now that we have discussed medications that alter cardiac output, let's discuss agents that alter SVR. In general, a low afterload state in cardiogenic shock is beneficial as it can promote cardiac output. Therefore, when blood pressure is adequately supported with inotropes, you can choose to add a medication that decreases SVR, for example, nitroprusside. Alternatively, if blood pressure is not adequate on inotrope alone, or possibly due to the vasodilatory effects of the inotrope itself, patients may require an additional agent to increase SVR and maintain adequate MAP. In these cases, norepinephrine, which has both alpha-1 and beta-1 effects, provides balanced arterial and venous vasoconstriction to augment MAP through both increased preload and afterload. Because of this, norepinephrine is one of 2 first-line agents, along with dobutamine, recommended in the European guidelines for the management of cardiogenic shock. Epinephrine is a non-selective adrenergic agonist that you will see used in the medical ICU, but the limited data that we have in cardiogenic shock suggests that norepinephrine is safer and no less effective. Therefore, you will not see it used in the management of cardiogenic shock. Phenylephrine is a pure alpha agonist which increases SVR and afterload, so it has a very limited role in cardiogenic shock. Likewise, vasopressin, which acts on vasopressin receptors in vascular smooth muscle, can be considered in cardiogenic shock with refractory severe hypotension, but otherwise does not have a role in standard management. Patients in cardiogenic shock who do not improve with first-line medical management should be considered for mechanical circulatory support, which will be discussed in another video. We've covered a lot of ground in this video, so let's review some key points. Cardiogenic shock is a state of end-organ hypoperfusion that is the result of low cardiac output. Etiologies of cardiogenic shock include systolic dysfunction, diastolic dysfunction, abnormalities of rate or rhythm, and structural abnormalities. Indications for use of ionotropic or vasopressor medications in cardiogenic shock include hypotension or persistent end-organ malperfusion despite initial management. Dobutamine and milrinone are first-line agents for management of cardiogenic shock and are equally effective for improving cardiac output and carry similar risks. Vasodilators such as nitroprusside can be used to decrease SVR if MAP is adequate, or vasopressors such as norepinephrine may be required when MAP is inadequate. Finally, mechanical circulatory support should be considered when patients fail to improve with first-line medical management. Thanks for joining. Be sure to check out the other videos in our Advanced Heart Failure Curriculum series for more learning.